Hi, I am Francesca Cerutti. Today I would like to share with you some thoughts about the Ryzen system, because the Ryzen revolution is a modern way to shape the root canal system for a predictable endodontics. But what do we mean with predictable? What makes our treatment predictable? Well, a root canal treatment becomes really predictable when anatomy, biology, and the technique leave as little room as possible for uncertainty. And so, in endodontics, predictability is something that is not casual, it's not a gift. It's something that we earn through repeatable procedures and a careful control of the variables. So we have to start with a correct diagnosis, because we know that if we make a treatment that is perfect, technically speaking, but we treat the wrong tooth, then we have a great failure and our endo is not predictable at all. So first of all, we have to formulate a correct diagnosis. That means that we have to match the clinical findings with the anamnestic records and the radiographic data, because we know that for some patients one treatment can be better than the other, and this is due to their physical condition, psychological condition, economical condition. So we have to evaluate all of these factors in order to find the best treatment planning for the patient. But still, we have to start from a correct diagnosis of the problem. And sincerely, most of the times, I want to see an X-ray. Some other times, I even want to see a CBCT in order to be sure that my diagnosis is correct and so that I am making the correct treatment planning for my patient. But what happens when we find pregnant patient? Because we had these problems in a practice. A girl, she was like 6 months pregnant, came in tears because she had pain, and the pain was unbearable. So we had to do something, but we were somehow blind, because of course we cannot take an X-ray in this case, in this specific patient. And so what we'll rely on? We just have to rely on the cold test, hot test, electric test if needed, and then percussion, palpation, probing. All the clinical findings that helped the colleague finding out which was the tooth responsible for her problem. She had an extensive restorative and prosthodontic work couple of years before, and she had symptomatic irreversible pulpitis on the upper right first molar. And so what my colleague would do was to open the tooth, remove somehow the pulp, and then medicate. And let's see, the following week she still was in pain, so I saw her and I removed some more pulp, etc., only relying on the apex locator for the working length, of course. And the pain went away. She obviously didn't come back until she gave birth to the child. And so this is how I saw her. She has a periapical lesion because, of course, she lost the provisional filling and she didn't consider that it was useful to come back and get a new one. And so this was the situation. The access cavity was filled with food remnants, etc. And so let's say that I irrigated more than I'm used to do for these cases. And I treated the tooth by following the rising protocol, so using the sequence. This is my master comb fit after the obturation, and this is the post-op, so we will follow up. But doing the correct diagnosis is not enough, because there is one big variable that we only can adapt to, which is anatomy. We cannot control anatomy, we can just learn how to deal with complex anatomies in the best way. And of course, there are some situations in which it is more challenging to do a root canal treatment, because if we have deep splits or mid-root splits, or maybe lower incisor with 2 root canals, etc., the chance of missing some part of the anatomy of the root canal system is higher, because maybe it's a bit unexpected and maybe we don't know that there could be this particular variation in this tooth, and so we don't look for it and we don't find it, because one of my professors used to say that you see what you're looking for. If you don't know that it exists, you are not going to identify it. And so that's, be careful and take some time to analyze the preoperative x-rays when we have them, because we might know even before opening the tooth that that particular tooth requires particular attention or care, because it has an unusual anatomy or a particular situation that requires us to be extremely more careful than a normal situation. And we know that missed canals are among the major reasons for failure of the root canal treatment. And the most missed canal is the 𝗵𝗃 𝗥𝗶𝘀 in upper molars. And so this is very important for us. Try to identify all the anatomy. And also be careful when we have confluences, because confluences are those situations in which if we don't find out as soon as possible that we have a confluence, we might engage one of our rotary files into the confluence area with the higher risk of file separation. And so we have to be careful even in this case. This is a patient that came to me because she had pain in the first lower molar, in the right hemiarch, and she had a crown on this tooth. So what I have to do first of all is to remove the crown, because I want to see what's underneath this crown, and I want to be able to do the root canal treatment without the problem of passing through the crown. Also because if you see here, the restoration that was holding the crown in place was decayed, and so I cannot do a root canal treatment through a crown with the decay underneath, because there's no sense in doing it. So first of all, I remove all the decay, I restore one of the proximal walls in order to be able to have a good isolation. I perfect my isolation with liquid dam, and then I start the rising sequence. So I start with the RR, and then I do some coronal pre-flaring using R1 in this case. So you see pecking motion up and down, and then I pass to a bigger file, the R2. In this moment, I'm not trying to arrive to the working length. I'm only working in the middle and coronal third of the canal. This is why I want to remove the coronal interferences. When I go to the working length with my manual file, then I can drive all my rising sequence to the working length. So I start with R1, and if this time I'm arriving deep, then of course I rinse in between the instruments, and then I go to R2. You see pecking motion, trying not to push, I leave the file going to the root canal, I remove it, clean the spice, etc. In this case, I use then the R4 and I leave R3 as the last file in the sequence. And later I will explain you why I changed the sequence of the files, because you have to remember that files are working for us, are tools in our hands. And so if we want to be predictable, we have to understand when maybe jumping from R2 to R3 is too much, and if I pass R4 in between the two files, it's much easier for me to finish with my R3. Okay, master confit, post-endo restoration immediately. I scan for a new overlay, okay, and that's the post-operative. And then curves. Curves are another thing that may scare some of us, because some curves are difficult to negotiate, above all when we have to increase the size of our files. And so we know that in some cases we cannot use extremely large files. But nowadays the Martensittig treatment that most of the files have can help us even in this case, because we can use bigger files than before without the fear that the files is going to separate because it accumulates too many stresses into the curvature. But if we want to be predictable in endodontics, we cannot forget the first rule: isolate. Isolation helps us improving the quality of our treatment and helps us working better, because a good, clean, isolated operative field makes much more easier our work, because we don't have the tongue, the cheeks, we don't have to retract, we don't have the problem of the liquid spilling into the mouth of the patient, so it makes our life easier. But the literature also says that if we use a rubber dam, the quality of our work improves. We have examples in post-endodontic restoration, but also in endodontic treatments done with and without rubber dam, and using the rubber dam increases the success rate. So there's a whole list of advantages if we choose to isolate correctly with the rubber dam. And so if we want to be predictable, we have to start from a good isolation and the operative field. And second, access. Access is the gateway to success in endodontics. Why? Because if we don't do our access cavity in a correct position and with a correct extension, our chances to miss some of the canals are higher. If the access is too small, probably the files that I will use subsequently will accumulate more stress and will be more prone to fracture. Probably if my access is too big, I will risk to have fractures of the tooth if I don't restore it properly with a crown. So these are also factors that I have to take into account. And it's funny, but if you see these three pictures, the type of access is the same, more or less. Remove the decay, long, H-shaped access cavity, yes. But those are three completely different teeth, because we have an upper second premolar, then we have a lower first premolar, and we have an upper second molar. So even access changes according to the anatomy of the tooth, but is basically what makes us able to provide to the patient a great root canal treatment. So there is no great endo, predictable endo, without a good access. And then the working length, because we have to remember that whatever file we want to use, we want to confine our instrumentation into the root canals. We don't want to overextend our instrumentation, and we don't want to be short in our treatment. And so we have to be able to record a correct working length. And in this, we can use periapical x-rays with the instruments inserted inside the root canal system, or we can use an apex locator. And sincerely, the most convenient and most reliable tool that you can use is the apex locator, because sometimes x-rays might lie. We might think that we are at the apex because we see that we are at the radiographic apex of the tooth, but maybe we are 2 or 3 millimeters long. And so let's pay attention. And then shaping. Shaping is one of the most discussed topics in endodontics because, of course, we have several ways to shape the root canal system. But what we want to achieve here is to make room for our medicaments, our irrigant, our obturation, get rid of all the debris, the bacteria that are inside of the root canal system, and then we want to try to preserve as much as possible the original anatomy of the tooth. So we don't want to make perforation, ledges, mishaps in general, and we want to keep the position of the foramen exactly where it was. We don't want to do apical zipping. We want to be conservative. And to be conservative, we need to have the right tools that help us in being conservative, reliable, predictable in a short time. And so here comes the rising system. The rising system is a system that in a single sequence has different alloys, different sizes of the files, but the idea is to have a different kind of cross-section according to the area of the root canal in which the file is going to work. Why? Because in some areas I need to be more efficient, more cutting. Some other areas I need to be more passive and just like brush the walls without removing too much dentine. And so the first file of this system, which is called RR, is a 17 in tip and 10 in taper. What is it meant for? This file is an orifice opener, an early coronal flarer. So it's meant to be used only in the first millimeters of the root canals, and its aim is to remove the coronal interferences. And then what I want a glider. I want something that can make me arrive to the working length and establish a glide path that will be followed by all the subsequent files. And so I have a R1 file, which is a 1303. So small file, short pitch, flexible, but in an alloy that makes it also cutting, resistant to the cyclic fatigue, resistant to the torsional stress. So it's a very useful file because it's the first file that will make and will set the path that will be followed in all your root canal treatment. And then I want to increase my preparation both in size and taper, and so I switch to the R2, which is a 2504. R2 is in a different alloy than R1 because it needs to be more flexible, a bit less cutting, but still extremely efficient. And then R3 is a 3004. So the taper remains the same. I just increase the size of the tip, but I change the alloy. And then the bonus file, the particular file of the sequence, which is the R4, which is a 2805. In this case, I can use this file in two ways, and I will show you later with some case and in the clinical sequences. If I feel like the jump between 25 and 30 is too big, I might like to use this 2805, which, being 05, just enlarges a bit more the last millimeter of the root canal system, making it easier for my 30 to go inside and just shape the foramen. And so it's a very interesting file. How do I use them? I set my endomotor in continuous rotation forward at 450 rotation per minute and 2 Newton torque. This is an example of a treatment that I did in a second lower premolar in a patient sent to me by a colleague who had done the onlays on the 35 and 36, and then had started the emergency treatment because the patient was in pain. So he asked me to maintain the onlay that he did, so I tried to do it initially. I did a multiple isolation, I removed the provisional restoration that he did, and then it was quite easy to arrive immediately to the working length. So I go straight to the working length with my R1, then I switched to R2. I didn't use RR because I had no coronal interfaces to remove, I have no orifice to open, so there was no need to use it. And then there's room enough to go to the R3. And then I irrigate. I enlarge a bit more the foramen because I had the visual gauging at 35, so I enlarge it at 35, and I do my endodontic filling, so hydraulic sealer and modified warm vertical compaction of the 𝗧𝗵𝗃 𝗥𝗶𝘀𝗶, and then the onlay just fell out, so I did a post-endo restoration, I took an impression, and I cemented a new onlay in a following appointment. But sometimes it's difficult to solve the puzzle because the variables that we encounter make it more difficult for us to be able to provide a predictable endodontics, because in this case I have the curvature, I have the small mouth opening, and I had the position of the tooth, which was not easy, but with the rising system I was able to shape correctly this tooth. And then irrigation. We don't have to forget that irrigation is a crucial part of the endodontic treatment, because if we don't irrigate correctly, we leave a very significant amount of bacteria and debris inside of the root canal system. And so this is something that we want to avoid as much as possible. So here's an example. You see the bubbles, the champagne bubbles created by the action of sodium hypochlorite that is disarranging the organic tissue that is inside of this tooth. And you see, as long as you see these bubbles, means that sodium hypochlorite is still active and is working. And then I start my treatment. So RR to enlarge the orifices. You see here, I try to keep my cavity as conservative as possible. I did a caries driven access because I want to save as much sound tissue as I can. And then R1. See upper 7, MB1, MB2, distal buccal, palatal, and then I switch to R2. MB1 and MB2 here, they are confluent, so I spot it early and I know where to stop in my shaping in the MB2. After the coronal pre-flaring, I arrive to the working length with all the files of the sequence. R3, when the treatment is difficult, you might need to pass all the sequence short from the working length and then start again. R1, R2, R3, R1, R2, R3 until you arrive to your 0.0 reading. You see, I put the 𝗧𝗵𝗃 point in the main canals and the file in the MB2. Irrigation, activation of the irrigant, that is important as irrigating itself, because irrigants need a push to get into the canal and need a push in the apical direction. And here is the filling. Obturation. Obturation is very important because once we remove the bacteria, we have to prevent them from reinfecting the root canal system. We have to fill the empty space that we created. And so how do we choose? In this case, anatomy dictates the rules, because in some cases I can use whatever I want. In some other cases, it's more predictable to use a single cone technique with a hydraulic sealer. In other cases, it's better to use a worm technique in order to 3D fill the space. In other cases, I can treat one canal in one way and another canal in a different way, because maybe one is extremely curved and the other one is straight and wide. So we have to adapt to the anatomy of the tooth, but also to the size of the foramen, because in a small size I can use most of the technique. In a large foramen, maybe I have to use MTA or 𝗍𝗵𝗃 𝗶𝗀. And so, of course, even in this case, I choose the technique, but I have to choose basing on the anatomy of the tooth. And also I have to choose according to what I have, what is available in my practice. But the important thing is to follow a protocol, because if you are able to follow a strict protocol, you leave a very small amount of space for casualties or for luck. So you try to be as precise as possible and to be as strict as possible in your protocol in order to achieve a predictable result. And so the rising system here gives you some advice on how to use the files according to the difficulty of the case that you're treating. So for easy canals, you can use the RR to enlarge the orifice, then go straight to the working length with your manual file, and then R2 and R4, and that's it, as in this case for the treatment. In medium canals, maybe you use R1, R2 to the working length, and then you do the visual gauging and you see if you can increase or you have to increase the size of the foramen, or maybe it's fine to stop at 25. In moderate canals, you might use all the sequence without jumping some files, okay? So in this case, what do? Isolation, I remove the existing restoration, I enlarge with RR, and then R1, R2, R3. In one canal I stop with R3, in the other canal I enlarge even a bit more, up to 35. This is the filling of the canals. I have to place one post so I don't fill completely the palatal, because I want to optimize my time, so I don't fill completely the canal and then I take a bird to remove part of the gutta percha. I leave the canal that I want to use for placing the post empty since the beginning. And then I take an X-ray just to confirm that everything is okay, and I go with my restoration. I put an automatics because this tooth is going to get a crown, so I don't care about the contact points, and I do the post-endodontic restoration, and I send the patient back to the referral. Another case, the patient lost the restoration, so she started feeling pain and went for the root canal treatment. I removed the decay, I removed the existing restoration, what is left, okay? And then I refined the access cavity with ultrasonic tips. Ultrasonics help me a lot in seeing what I'm doing, in having a controlled action, because the cutting action is extremely smooth, and to just improve my workflow. Then RR to remove coronal interfaces, R1. I leave the instrument go into the root canal and I stop when I feel that it starts struggling. If I can arrive straight to the working length, I let it go. If I feel some resistance, I do pre-flaring. In this case, I arrived with no problems, so I use the R2. Then R3. visual gauging, R4. And then I see, if I have to enlarge more, I will enlarge more. If I don't, I just irrigate and activate the irrigant with an ultrasonic tip. And in the end, obturation, hydraulic sealer and 𝗥𝗶𝘀𝗶𝗃, which I slightly heat and pack. The fact of being able to control the temperature of my heat carrier in the e-heater allows me using the warm vertical compaction even with hydraulic sealers. Not all hydraulic sealers support it, you have to read carefully the instructions, but the one that I use can be used both with cold and warm techniques, so I can choose what I prefer according to the anatomy of the tooth. You see, I heat, I pack, I heat, I pack. This is the appearance of my canal. I'm satisfied with the depth that I reached. And so I use the e-filler in order to do the backfilling of the root canal system. If I had wanted to place a post, I would have not filled the canal, obviously. In hard cases, what do? I use the whole sequence, and I might need to switch between R3 and R4. This is a case of an upper molar, upper second molar. You see, I remove the decay, I open the access cavity, I find MB1, MB2, distal buccal, palatal, okay? But the shaping is extremely conservative. I finished with the R4, okay? Other case, upper premolar in a patient that has no possibility of putting implants or stuff, so we have to be extremely conservative. We have to save all the teeth that we can save with him. And you see that there is a huge lesion. I isolate, I remove the decay, I refine the access cavity, then I use RR to open the orifices and remove the interferences that I can find coronally. I want my files to have a straight line access to the canal. And then R1. I use a packing motion. I don't push. I just follow the path of the canal. I check the working length. And so I take my R1 to the working length that I have preset. After that, R2. I use it in the same way, so packing motion, up and down, R3, and R3 also in the other opening. You see the canals are confluent. You can see it better here when I irrigate. So I choose the easiest one and I shape it up to the foramen and the other one up to the confluence. But here I had the isthmus and I removed it in order to be able to remove as many bacteria as possible, because if we don't remove that little part of dentine, we create an area in which bacteria can do whatever they want because they are protected somehow from our cleaning action. Then, when I am finished shaping and cleaning, I fill. And then I backfill. I pack with my plugger. And this is the postoperative. But we have to remember that dentistry is one of the most operator-sensitive professions. And so the operator factor is extremely important, because the same tooth with the same file treated by two different practitioners can end in very different ways. And so we have to remember to train ourselves. We have to remember that our formation, our growth, is what will really help us in providing predictable treatments to our patient. And so the fact that you are here listening to me, for example, that you research and you read, etc., is a great plus, because you invest in yourself. And I think it's the most important thing that one can do to be a good dentist. Thank you very much for listening, and if you have any questions, I'm happy to answer.